Today I will report on the latest research data of the REACH-3 trial, which is a trial on ruxolitinib versus best available therapy for patients with steroid refractory chronic graft-versus-host disease. Chronic graft-versus-host disease is a serious complication that occurs in patients that have undergone allogeneic hematopoietic stem cell transplantation, and it occurs in 30 to 70% of the patients. The standard first-line therapy are glucocorticoids. However, more than 30% of the patients will become corticosteroid refractory or dependent, and both conditions are connected to a worse outcome. Ruxolitinib is a JAK1 and JAK2 kinase inhibitor that has been approved in Europe and the US for the treatment of steroid refractory or dependent chronic graft-versus-host disease based on the results of the REACH-3 trial. Now, at this EBMT in Paris, we report the efficacy and safety results of patients who crossed over from BAT to ruxolitinib and completed either the duration of the treatment or discontinued the study. So per definition, the crossover treatment period was up to crossover week 24, and the endpoints that we assessed were overall response at crossover week 24 and best overall response at any time during crossover. Crossover criteria were disease progression, mixed or unchanged response, toxicity to BAT, or chronic GvHD flare. Over 1/3 of BAT patients crossed over to the Rux arm, and 33 patients discontinued treatment during the crossover period. The main result of the study that we performed here is that overall response in the crossover arm is consistent with Rux randomized patients, indicating that patients who crossover can still achieve a comparably high response rate as patients that were primarily in the Rux arm. Overall, the adverse event profile of Rux in the crossover group was consistent with that seen in the primary analysis of the patients that were randomized in the ruxolitinib arm. And the main cause of death in the crossover group was infection with an N of 3 patients. Ruxolitinib led to high response rate in patients who crossed over from BAT, and overall response at crossover week 12 was 47% versus 49% in the Rux arm at primary analysis, indicating that there's no statistically significant difference, indicating that even if a patient has failed best available therapy and is then treated with ruxolitinib, you can still achieve high response rates. As I said, no new safety signal were observed in this crossover period, and the analysis demonstrates that ruxolitinib has a manageable side effect profile and still leads to high efficacy rates in patients with steroid refractory chronic GvHD who have experienced treatment failure with other systemic therapies besides corticosteroids. With that, I'm at the end of my presentation. I hope you enjoyed watching. Thank you.